Alright. Okay. Welcome back, guys. Now in this video, let's discuss about the remaining topics in the reproductive pathology. Already in the last class, we have discussed about the cervical cancer. Okay. Also, we have seen about the endometriosis. Now in this class, let's continue with the genital infections. Now the first topic in the genital infections, which I want you to know, the very important topic. Okay, the genital infections. One question will be definitely coming in your exam. The first topic that I'm going to discuss here is bacterial vaginosis. See, in the bacterial vaginosis, let's keep it as simple as possible. Like, here we'll be integrating gynae and microbiology as well. So the point which I want you to know is, so what is the most common cause of the discharge? Okay, the most common cause of the vaginal discharge, the discharge from the vagina in the reproductive age groups. Okay, in the reproductive age group female, the most common cause of the discharge is going to be bacterial vaginosis. Okay, now she is having infection in the vagina because of certain microbes. Okay, so that's causing the discharge. So bacterial vaginosis, sir. So what is the organism responsible? Which organism is going to cause the infection? See, it's going to be like multiple organisms that can lead to this bacterial vaginosis. Okay, it's vaginosis, not vaginitis. Okay, there is no inflammation, just there is infection with the discharge. What are the organisms responsible is Gardnerella vaginalis. Okay, every student knows this, the most common organism. But in one of the recent exam, it was asked, all of the following can lead to bacterial vaginosis except kind of questions was asked. So you should know Gardnerella vaginalis, Mobilinska species, bacteroids, mycoplasma, ureoplasma and peptostreptococcus. All these organisms can lead to the genital infection, especially the bacterial vaginosis. Okay, bacterial vaginosis. Now what is the pathology? See, normally in the vagina, there is lactobacilli. Lactobacilli is present. Okay, lactobacilli is present normally. See, this lactobacilli is the one which produces the acidic environment in the vagina. Okay, lactobacilli, which is a healthy bacteria, it's usually present in the vaginal canal and it always produces what? It produces the lactic acid kind of thing, so that acidic environment is maintained. Because of this acidic environment, there is no growth of bad bacteria in the vagina. But if you lose this lactobacilli because of any reason, the normal flora is lost. Okay, if you lose the normal flora, the acidic environment is automatically lost. When you lose the acidic environment in the place of good bacteria, now bad bacteria takes over, leads to infections. So normal vaginal flora are replaced by the Gardnerella vaginalis. So the most common organism, the lactobacilli, is replaced by the Gardnerella vaginalis. Okay. So what happened to the vaginal pH? Now the vaginal pH, which was supposed to be acidic, somewhere around 3.5, now it is increasing more than 3.5, which is getting more alkaline. There is reduction in the acidic nature. Okay, that's the point which I want you to know. What is the investigation of the choice? Is going to be saline microscopy. Okay, you just take the discharge, okay, put it under the microscope and see. What you will see is the clue cells. Clue cells are present. Now you will get a question, what are these clue cells, sir? Clue cells are nothing but the vaginal epithelial cells, okay, the vaginal epithelial cells with which lots and lots of bacteria that are attached. Okay, so to this vaginal epithelial cells, lots and lots of bacteria are attached, so these cells are called as the clue cells. Okay, under the microscope you can see this. Now how the discharge is going to be? See, they will say the discharge is going to be foul smelling, okay, dirty, white discharge. Okay, so it's dirty white discharge, not the curdy white discharge. If they use the word curdy white discharge, then it's going to be a totally different condition. It's going to be a dirty white discharge without any itching. So dirty white discharge is different, curdy white discharge is different, green yellowish discharge is different. Okay, so dirty white discharge is going to be seen. Okay, that's the point which I want you to know with the clue cells. Now, what is the gold standard investigation? The gold standard investigation is to do the staining, gram staining. Okay, to know the organism. Okay, so gram staining is done. Apart from that, there is a scoring system. Okay, there is a scoring system which is employed for the diagnosis of the bacterial vaginosis. The scoring system name is called as the Nugent scoring. So I don't want you to go in detail what exactly is this Nugent scoring, what are the parameters which are taken for this Nugent scoring. I don't want you to go into that much details, but simple, a score greater than 7. If the score is greater than 7, yes, it indicates bacterial vaginosis. So gold standard, gram staining, investigation of choice, saline microscopy, where you will see the clue cells. The scoring system is called as the Nugent scoring. Now you can do this test, which is called as a whiff test or amine test. So you can ask me, what is this whiff test or amine test, sir? So take this discharge and put some potassium hydroxide to it. Okay, take the discharge and add some potassium hydroxide. Now immediately an intense foul smelling is going to come. Okay, when you have the intense foul odor, fishy odor, when you get this fishy odor, then you can say this KOH test is positive, the whiff test is coming positive, which is usually seen with bacterial vaginosis. Okay, so if you add 10% potassium hydroxide to the discharge, you will get the bad foul smelling, like smell will come, intense fishy odor will come. That is whiff test. So what is the treatment? Simple treatment is going to be with metronidazole. Okay, metronidazole. 500 milligrams for 7 days, 2 times a day for 7 days. Metronidazole is a drug of choice. As it's not a sexually transmitted disease, there is no need to treat the partner. Done. Next, bacterial vaginosis is completed. Now, still some important points which I want you to know. The keywords which I want you to know for bacterial vaginosis is same. See, Amsel's criteria. What is the criteria used for the diagnosis? Scoring system is Nugent scoring. Okay, what is the criteria to say, okay, this fellow is having this, this female is having bacterial vaginosis? They must have at least 3 out of all this following. Okay, out of the following, at least 3 should be there. What are they? Vaginal pH more than 4.5. I have said you, because of replacement of the lactobacilli with some other organism like Gardnerella, the pH is now increasing. One thing, presence of more than 20% per high power field. What is this more than 20%, sir? Clue cells. Okay, so more than 20% of the clue cells are present in the discharge. That's considered as a criteria. Positive amine or whiff test. If there is a positive amine test or whiff test, that is adding 10% potassium hydroxide to the discharge, is going to give the intense fishy odor. So that's one of the criteria. And homogeneous, non-viscous, milky discharge. Okay, so this is also considered as a criteria. So out of these 4 criteria, if there are 3 criteria present, then it is considered as bacterial vaginosis. Done. Okay, diagnosis completed. Now let's discuss about the second genital infection, that is candidiasis. So candidiasis, in the name itself, it's a fungal. Okay, so what is the organism responsible? Is the Candida albicans. Okay, there are multiple organisms like Candida gagalbata, like some other species are also there, but the most common organism is going to be Candida albicans. It's a fungus, fungal infection. Now let me tell you, every time I say this thing, fungus does not have the guts to infect the humans usually, because we are having proper immune system, potent immune system is there, we are immunocompetent, so usually fungus won't affect us. Until unless you are immunocompromised, you are a HIV patient, or you are a steroid user, or during pregnancy, during the use of oral contraceptive pills. So in immunocompromised patients, they can get these candidal infections. So pathology, it is seen in immunocompromised states like diabetes, the immunocompromised state like pregnancy, steroid users, OCP users, HIV patients. All these patients are categorized under immunocompromised states. Okay, so these females can get the fungal infections in the vagina. So what you will see under the saline microscopy. So take this discharge, even these fellows will be having a discharge. Take this discharge, put it under the microscope and see what you will see. Fungus. What else you will see? You will be seeing bacteria. No, it's you are going to see the fungus. So fungal hyphae, pseudo hyphae, spores, budding yeast, all these fungal components are going to be present. Okay, pseudo hyphae, spores, budding, all these things will be seen under the saline microscopy. So how the discharge is going to be, sir? In bacterial vaginosis, how the discharge? The discharge is going to be dirty white discharge there. Here also white discharge, but it's looking like a curd. The consistency is going to be looking like a thick curd-like. So curdy white discharge is going to be seen with intense itching. This is the keyword. In bacterial vaginosis, there is no itching. Here there is very intense itching, and this is the one vaginitis, one infection where the pH is still maintained 4.5. So this is the question which was asked, which infection can still occur in a pH which is still acidic, that is less than 4.5. It's going to be candidal vaginitis or the candidiasis. Okay, so what is the gold standard investigation? Is the culture, like you are taking the discharge and you are growing this fungus on taburats and Nickerson's medium. So growing this fungus is the gold standard. And what is the treatment? So antifungals like fluconazole and miconazole. Simple. Okay, so this fungus even can spread to the partner. So both the partners can be treated, though it is not a sexually transmitted thing, but still advised to treat both the partners. That's sexual partners. Okay, both male and female. So simple. What are the important points which I want you to know? What is the most common causative organism? Candida albicans, seen in immunocompromised individuals like OCP users, steroid users, HIV, diabetes, pregnancy, all these conditions. What you will see on the microscopy? Fungal hyphae. Okay, budding yeast can be seen. And however the discharge is going to be curdy white discharge with intense itching. What about the pH? The pH is still maintained less than 4.5. What is the gold standard? The gold standard is culturing this organism on Seborrheics and Nickerson's medium. And what is the treatment? It is fluconazole, miconazole. Now, the last infection which I want to discuss here is the trichomoniasis. Okay, trichomoniasis. See, this trichomoniasis, what is the organism responsible? The organism responsible is Trichomonas vaginalis. Okay, Trichomonas vaginalis. Look here. This is the cervix. How the cervix is looking like? The cervix is looking like a strawberry with all these spots. Okay, with all these spots, the cervix is looking like a strawberry. So this is called as the strawberry cervix, or which is also called as a colpitis macularis. Okay, so all these macules can be seen. So colpitis macularis, which is also called as angry looking cervix. Okay, so what is the organism responsible? Trichomonas vaginalis. Question is, how you will get this? In immunocompromised? No, it's going to be sexually transmitted disease. It can resist STD. So as it is an STD, so this infection, whatever is happening in the vagina, it is also going to produce the discharge. So what kind of discharge, sir? The discharge is going to be greenish yellowish discharge. Okay, the discharge is going to be greenish yellowish discharge. Foul smelling green yellowish discharge is going to be seen. If you do the examination, vagina, I have said you, it's going to be strawberry vagina or angry looking vagina. Okay, with lot of macules which is present over the cervix. Okay, so angry looking cervix, angry looking vagina, you can use the words. Investigation of choice. Again, same saline microscopy. If you do the saline microscopy, what you will see? You will see clue cells, or you will see hyphae and pseudo hyphae. No, what you will see is this flagellated organisms. Okay, happily dancing in the they are happily dancing in the vaginal secretions. Okay, so this flagellated organisms can be seen. Okay, motile flagellated organisms which are seen. So what is the gold standard investigation? Again, culture. Okay, so culture on Feinberg Whittington's media. Okay, Feinberg Whittington's media and diamond media are used to culture this organism. And pH, again, see, pH is increasing. So in bacterial vaginosis, pH is increasing more than 4.5. Even trichomoniasis, the pH is more than 4.5, that is 5 to 6. But in Candidal infection, like candidiasis, the pH is still maintained less than 4.5. What is the treatment? Again, metronidazole, 500 milligrams for 7 days. You have to treat both the partners, as it is STD. Okay, as it's a sexually transmitted disease, treat both the partners. Okay, for candidiasis also we will do treatment for both the partners, as well as for trichomoniasis also the treatment will be done for both the partners. So with this, the infections part is completed. Okay, the 3 infections which I want you to know for your exam: arm cells criteria, bacterial vaginosis; Gardnerella vaginalis, bacterial vaginosis; clue cells, bacterial vaginosis; Biff test, bacterial vaginosis. Okay, flagellated motile organisms in the vaginal discharge, trichomoniasis; STD, trichomoniasis. Okay, Seborrheics media, fungal. Okay, that is candidiasis. So with this, trichomoniasis is completed, sir. Now the next topic which I want to discuss here is the ovarian cancer. Okay, so the next topic which I want to discuss is the ovarian cancer. Now in the ovarian cancers, I will be, see, again this topic is going to be integrated with your gynecology also. Okay, so I will be mainly concentrating on those points which are important for your exam. From the pathology, whatever I should teach you, that I will be concentrating. See, look here. See, the ovarian cancers can be benign, it can be benign, or it can be malignant. Okay, it can be benign, it can be malignant. Let me tell you some basic points how to differentiate between a benign and malignant thing. See, these are not exact clear-cut demarcations. No, usually speaking. See, benign masses are going to be most commonly seen during reproductive age groups. Okay, in reproductive age group females, she will get benign tumors, not cancers. But malignant are going to be seen in extremes of the age, either prepubertal age groups or post-menopausal age groups. Okay, extreme age groups. And benign are going to be unilocular. Okay, it's going to have one single septa, like in a unilocular. And they are going to be mostly cysts, okay, fluid-filled cavities. But malignant, they are going to be solid with thick septa, with papillary projections are going to be seen. Okay, and benign masses are usually one side. Malignant are going to be bilateral. Okay, malignant are going to be bilateral, benign are going to be unilateral. Now, having said that, now let's see what are the risk factors for getting a ovarian cancer. Who will get the ovarian cancer, sir? Which females? Pathology important. So the risk factors include early menarche or late menopause. Okay, early menarche and late menopause, just keep it this way. So more the times ovulation, more the work on the ovaries. Let's simply keep it that way. Okay, more the times menstruation, early menarche, late menopause, more number of reproductive cycles, more menstrual cycles, more stress. Okay, So that can lead to ovarian cancer. Obesity. Why obesity? Simple. Obesity means she is having a lot of adipose tissue. As she is having a lot of adipose tissue, she will be having peripheral aromatization is happening. That will lead to the production of more estrogens. Estrogens are one of the risk factors. Hyperestrogenism, super high levels of estrogens can lead to the ovarian cancers. Okay, endometriosis. Yes, endometriosis is a hyperestrogenic state. Okay, so endometriosis can lead to endometrioid type of ovarian cancers. Endometriosis happening in the ovary. Okay, endometriosis happening in the ovary is going to cause the chocolate cysts in the ovary. Those chocolate cysts can turn into the cancers. So endometriosis is a risk factor, or for that matter, any condition which increases the estrogen levels is a risk factor. So in early menarche, late menopausal females, high levels of estrogens will be there. Obesity increases the estrogen levels. Endometriosis, like it's because of the high estrogen levels. Nulliparity. Nulliparity means simple, she is not a pregnant. Okay, she is not a pregnant. Continuously she is having the reproductive cycles. There is no break. Okay, if, for example, say if a female is having 2 babies. Okay, if a female is having 2 babies, there is almost 3 years break from the menses. Okay, 2 years of gestation and half year of lactational amenorrhea. So there is going to be almost 3 years of break. Okay, but if she is nulliparous, she is not having a baby, she is continuously going to have the reproductive cycles, ovaries like ovulating. There is a chance that she can have overstress the ovaries. There is a chance that she can get the mutations and cancer. Okay, infertility, again no babies. Okay, asbestos is shown to cause the ovarian cancer. Okay, asbestosis and certain mutations like in BRCA1 mutation, BRCA2 gene mutations. Okay, BRCA1, BRCA2 gene mutations, Lynch syndrome. Okay, Lynch syndrome, which is also called as hereditary non-polyposis colorectal cancer, where the patient is going to have multiple cancers. Okay, like breast cancer, ovarian cancer. Okay, endometrial cancer can be seen. PCOS, polycystic ovarian syndrome. Okay, we'll discuss about this also. I have already made a video on PCOS. So PCOS is also a risk factor for the ovarian cancer. So mainly these things. See, the points which I want you to know is ovarian cancer is going to be seen mainly nulliparous, infertile, early menarche, late menopause females, hyperestrogenic conditions like PCOS, endometriosis condition. So in all these conditions, the female is at a risk of getting ovarian cancer, and certain mutations like BRCA1, BRCA2 gene mutations, as well as the Lynch syndrome. Okay. So and HRT also, hormone replacement therapy. Okay, if she is taking the hormones after the menopause, if she is artificially taking the estrogens, then there is a risk of breast cancer, ovarian cancer, and uterine cancer. Okay, ovarian cancer risk is there. Okay, and ovulation inducing drugs. Certain drugs will cause the ovulation. Clomiphene citrate, letrozole. They are the ovulation inducing drugs. Means causing the stress on the ovaries. There is a chance of ovarian cancer. Okay, and perineal talc, using certain talcum powders. Okay, so females who are using the talcum powders in their genital areas, okay, they can also, the talc can get access into the reproductive tract, and it's shown that it can also lead to ovarian cancers. Okay, smoking. So smoking is definitely a risk factor. It's a bad thing, right? Smoking is having lots and lots of toxins, having a lot of carcinogens, so that can lead to a cancer. Okay, so all these are the risk factors of ovarian cancer. Now, after this, the points which I want you to know is, see, some important points for your exam. Okay, sir, what is Lynch syndrome? Okay, that's very much important in the pathology also. Lynch syndrome is autosomal dominant disorder. Okay, even in GI pathology also I have discussed. Lynch syndrome is going to cause colon cancer. Okay, colorectal cancer. Lynch syndrome. It's autosomal dominant disorder. Okay, see, colorectal cancers can be present. The female can have colorectal cancer, endometrial cancer, ovarian cancer, and gastric cancer. So if a female is having Lynch syndrome, she can have all these cancers. See, ovarian cancer also 20% chances of ovarian cancer. Okay, it's autosomal dominant condition. Okay, let's talk about the BRCA1 and BRCA2 gene mutations. See, if a female is having BRCA1 gene mutation, okay, BRCA1 gene which is present on the chromosome number 17, so there is maximum risk of ovarian cancer, maximum risk. Okay, imagine this is a female who is having BRCA1 gene mutation. Okay, so she is having 40% chance that she can have ovarian cancer. 40% chance. Okay, for the ovarian cancer. If she is having BRCA2 gene mutation, 15% chance of she getting into the ovarian cancer. 15%, 40%. BRCA1 is more dangerous. Okay. For example, say if a first degree relative with ovarian cancer, okay, or BRCA1 mutation, risk of ovarian cancer is 2 to 10%. For example, imagine there is this one female. Now, her mother or her sister is having BRCA1 gene mutation. Okay. Now, this female getting the ovarian cancer, the risk of ovarian cancer is almost 2 to 10%. Okay. Annual screening. So, these females whose relatives, okay, this female whose relatives are having BRCA1, BRCA2 gene mutations, okay, especially BRCA1 gene mutations, they have to go for the transvaginal sonography and CA125 levels every year. Okay, they have to check every year because they are at risk of getting these ovarian cancers. As there is high risk, okay, these females are having a high risk of getting ovarian cancer, right? Okay, if she is having BRCA1 gene mutation, now for example, she is a known case of BRCA1 gene mutation. Now there is 40% chance that she can end up in ovarian cancer. So what she have to do? She have to, once her family is completed, remove her ovaries. Okay, remove her uterus because there is a risk of uterine cancer also. Okay, so total abdominal hysterectomy as well as bilateral salpingo-oophorectomy. So once the family is completed, once she says, sir, done, I am done. Like my family is completed, I don't want to conceive in the future. Then you can go with the total abdominal hysterectomy as well as bilateral salpingo-oophorectomy. Done. Okay, so Lynch syndrome, BRCA1, BRCA2 gene mutations. High chances of cancer with BRCA1. Present on chromosome number 17. Okay, 40% chance. BRCA2 gene mutations, 15% chance. Next, sir, let me tell you some important protective factors against the ovarian cancer. Okay, what are the protective factors? Say, protective factors are multiparity, more the number of children, more like vacation for the ovaries. Simply they are resting, they are happily, they are, they are taking rest. So multiparity, oral contraceptive pills. Okay, so oral contraceptive pills, she's taking the contraception. Okay, it's just like it induces the pseudo pregnancy states. Okay, pseudo pregnancy states, and the oral contraceptive pills are also seen to be protective factors. Okay, from ovarian cancer. Lactation, giving lactation. Till the time she lactate, there is not going to be menses. Lactation, amenorrhea are going to be there. So there is no stress on ovaries. Simply they are relaxing. Hysterectomy. Okay, you have done the hysterectomy, salpingectomy, you have removed. Okay, hysterectomy, salpingectomy, you have removed the uterus. Okay, uterus along with the ovaries also, for example. There is no chance that she can get into the get cancer, right? So simple, as simple as that. Okay. Now, after discussing the most important topic, okay, the heart for the today's topic is how many different types of ovarian cancer? How many types of cancer, sir? See, here in the ovary, you can see different types of cells. These are the surface cells. Okay, imagine I am showing the cross section of the ovary here. This is the cross section of the ovary. Here you can see the surface epithelial cells. Okay, inside you can see the stroma. Here are the follicular cells. Okay, so there are multiple cell types in the ovary. So there can be multiple tumors possible. Okay, so from the surface epithelial cells, you can have different types of tumors. From the follicular cells, you can have different types of tumors. From the stomal cells, you can have different types of tumors. So let me begin. The ovarian tumors. So tumors, epithelial ovarian tumors. Tumors are arising from the surface epithelial cells. Okay, epithelial ovarian tumors. They are coming from the epithelial cells. Okay, germ cell tumors. They are coming from the germ cells. Okay, and six-card stromal tumors. They are coming from the stroma. Okay, stroma. They are coming from the germ cells. See, germ cell tumors are coming from the germ cells, the follicles. Okay, the germ cells, like whatever the germ cells are there, from them it's coming. Okay. So metastatic tumors. What are exactly the metastatic tumors? Metastatic tumors means the tumor, that the cancer which have originated somewhere outside, maybe from the stomach, and it is coming to the ovary, and there it's getting settled. Now, let's begin our topic, sir. First, let's begin our topic with the epithelial tumors, epithelial ovarian tumors. So how many types of epithelial ovarian tumors are there, sir? Serous tumors, mucinous tumors, Brenner's tumor, endometrioid tumor, and clear cell tumor. See, regarding everything, there are 3-4 important points are there. If you know those points, enough. So again, what are the epithelial tumors? The epithelial tumors are going to be serous tumors, mucinous tumors. Okay, serous and mucinous we will be discussing in a comparison way. Serous tumors and mucinous tumors, Brenner's tumors, endometrioid tumors, and clear cell tumors. All these are coming from the epithelial cells. Okay, all they are coming from the epithelial cells of the ovaries. Okay, next, germ cell tumors. Germ cell tumors are teratoma, okay, dysgerminoma, yolk sac tumor, embryonal cancer, choriocarcinoma, and mixed type. But first, rather than discussing everything now itself, first let's start with the epithelial tumors. First, let's begin our topic with the epithelial ovarian tumors. Okay, so look here. The epithelial ovarian tumors, the first type which I am going to discuss is the serous tumors I have explained you, and mucinous tumors. Serous and mucinous tumors. Who is more dangerous? Serous tumors are more dangerous. Okay, so these are the most malignant. Means first they will start as adenomas. See, benign serous tumors are called as serous cystadenoma. Serous cystadenoma is a benign tumor. It will turn into cancer. Malignant is called as cystadenocarcinoma. Cystadenocarcinoma. So serous tumors are of two types: serous adenoma, serous cystadenocarcinomas. Okay, they are most malignant, dangerous guys. Okay, so how many ovaries are going to be involved in serous tumors? Usually bilateral. Okay, this is the key word. Usually bilateral. Most of the times it is bilateral. Both the sides is going to be affected. What is the gene involved? BRCA1, BRCA2 gene mutations. Okay, BRCA1, BRCA2 gene mutations can lead to the serous cystadenomas that can turn into serous cystadenocarcinomas. Bilateral involvement, BRCA1, BRCA2 gene mutations, even P53 gene mutations can be seen. So these cancers, what they will release? They will release CA125. It's a tumor marker. They secrete. Okay, CA125. So CA125 is a marker of ovarian cancer. Okay, of course it is not specific. The CA125 levels are also elevated in uterine fibroids, endometriosis, but CA125 levels are usually raised. What is the gross appearance? If you look at the gross appearance, it's a uniloculated cyst with serous fluid. It's like a cyst. See, it's like a cystic cavity. Once you open the cystic cavity, there is nothing. It's just a fluid-filled cavity. Okay, it's a uniloculated. It's not multiloculated. Just a uniloculated, one single cyst. Okay, so gross appearance is going to be uniloculated cyst filled with the serous fluid. Microscopic appearance, what you will see? Sir, microscopic appearance, serous cystadenomas, other cystadenocarcinomas, what you will say is samoma bodies. Okay, so samoma bodies, very, very important. What are samoma bodies? Samoma bodies are nothing but the calcium deposition, dystrophic calcium deposition around the tumor cells. Calcium is coming and depositing in the lamellated pattern. Okay, in the lamellated pattern, if the calcium is coming and getting deposited, so that dystrophic calcification is called as samoma bodies. Smoking is not seen as a risk factor for them. Okay, smoking is not a risk factor. So let again repeat: serous tumors, two types: serous cystadenomas, which are benign, and serous cystadenocarcinoma, which are malignant. Okay, they are the most malignant. They are uniloculated with a serous fluid. Samoma bodies are going to be seen associated with BRCA1, BRCA2 gene mutations. P53 gene mutations can also be seen. Okay, so the tumor marker is going to be CA125. Now let's talk about the mucinous tumors. The mucinous tumors are also epithelial tumors of the ovary. Okay, mucinous tumors are also the epithelial tumors, epithelial ovarian tumors. Now let me talk about the mucinous tumor. See how the tumor is in the ovary. Okay, how the tumor is. So it is multiloculated. See, multiloculated, multiple thick septa are going to be seen. Okay, so it is less malignant condition. Okay, benign, it is called as benign. Okay, is called as a mucus cystadenoma. Most of the times, 80% of the times, the mucinous tumors are not malignant. 80% of the time it is mucinous cystadenomas. Malignant is simple mucinous cystadenocarcinomas. Mucinous cystadenocarcinoma. So usually it is unilateral, but serous is bilateral. Most of the time, 50% of the time it is bilateral. Here it is usually unilateral. Okay, only bilateral in 10% of the cases. Why, sir? Serous cystadenomas or cystadenocarcinomas are because of the BRCA1, BRCA2 gene mutation. Here it is because of KRAS mutation. There the serum marker, okay, the cancer marker is CA125. Here the marker is carcinoembryonic antigen, okay, and CA19-9. CA19-9, we have also discussed this in pancreas. Okay, pancreatic cancer, CA19-9 levels will be elevated. Okay, next, sir, these are multiloculated. Just now I have shown you multiloculated. Again, cyst filled, okay, cystic with the mucoid material, not the serous fluid, thick mucus-like material. Okay, mucoid material is going to be seen. Here, serous material is going to be seen. In serous, it is serous material. In mucinous, it is mucoid material. Now, what is the lining? How the lining is? See, the lining epithelium is going to resemble like endocervix. This is one thing which I haven't explained here. See, here the lining epithelium is like fallopian tube, MCQ. In serous tumors, the lining epithelium is resembling It resembles the fallopian tube lining. Very, very important point. And here in mucinous tumors, the lining is going to resemble the endocervical lining. Okay, done, sir. So smoking is not a risk factor for serous, but smoking is a risk factor for mucinous. How I used to remember is, say, for example, when you are smoking, bronchitis will come, right? Chronic bronchitis with lots of mucus production will be there. So smoking is usually always associated with the mucus. So in the same way here also, what I want you to know is smoking is a risk factor for mucinous, not only in the lung, but also now mucus is getting produced in the ovary also, sir. Okay, just remember like that. Okay, so mucinous cancers, smoking is a risk factor. Okay, so pseudomyxoma peritoneae, I don't want to go in that much details. Okay, these are producing lots and lots of mucus, right? So that actually causes the hypoproteinemia. Unnecessarily the mucus is getting produced. Okay, so that mucus is a proteinaceous material. Okay, mucus is a proteinaceous material. So hypoproteinemia can be seen. So with this, the differences between serous cystinoderma and mucinous tumors are completed. Okay, are completed, sir. So some important points. The most common ovarian tumor, if they ask you, what is the most common ovarian tumors? Serous cystadenomas, benign cystadenomas. Most common ovarian cancer, most common, again, serous cystadenocarcinoma. Okay, cystadenocarcinoma. Done. Next, Brenner tumor. Now let's discuss about the Brenner tumors. Okay, Brenner tumor. See, this Brenner tumor, again, it's a epithelial tumor. We are discussing about the third tumor, the Brenner's, this one. Okay, out of all this, epithelial ovarian tumors are the most important. Okay, germ cell tumors next most important. So first, let's mainly concentrate on the epithelial tumors. Very, very important. Next, Brenner tumors. See, regarding Brenner tumor, what you should know is, sir, it's a solid tumor. It's not a cyst, and it's a benign tumor. Brenner for benign. Okay, Brenner for benign. So it's going to have the rubbery consistency. Okay, look at it, how it is looking like it's a solid. It's just going to have the rubbery consistency. Okay, now why I have shown here the nest is because under histology what you will say is this nests. Okay, these are called as the tumor cells which are arranging in the form of a nest, which are called as the Walthard cell nest. Okay, Walthard cell nest is going to be seen in Brenner tumor. Okay, what else, sir? See, if you look at this cancerous cells with high magnification, see the cells are going to look like a coffee bean. Okay, nucleus, actually that's the nucleus of the cell. Okay, so it's going to have the coffee bean nuclei. Coffee bean appearance is going to be seen. Okay, so coffee bean nuclei is going to be seen in which type of cancer? It's going to be seen in Brenner tumor. Brenner tumor, nests are going to be seen. Nests are going to be seen. Walthard cell nest, coffee bean nuclei going to be seen. Rubbery consistency, benign tumor. Okay, solid tumor, 100% unilateral. Okay, it's a benign tumor, right? Most of the time benign tumors are unilateral. So 100% it is unilateral, not bilateral. Serous, think about the serous. Serous tumors are bilateral. Mucinous tumors are unilateral. Brenner tumor is unilateral. Okay, Brenner tumor is unilateral. So what is the lining epithelium? The lining epithelium is going to be very much important question. Transitional epithelium, looking like the bladder. Okay, the appearance is going to be similar to the bladder epithelium. Okay, transitional epithelium. In the bladder, what do you have? In the urinary bladder, which bladder? Urinary bladder. Which kind of epithelium you are going to expect? Transitional epithelium. So same type of transitional epithelium is going to be seen in Brenner tumor. Okay, in serous cystadenoma, again I am asking, serous tumors, it's going to resemble fallopian tube. Mucinous tumors are going to resemble, okay, the mucinous tumors are going to resemble endocervix. The Brenner tumor are going to resemble the urothelium, okay, the transitional epithelium of the bladder. So on histopathological examination, what you will see is the Walthard cell nest with the coffee bean nuclei. Okay, so this is also seen in granulosa cell tumors. We'll discuss it later. Now association with, see, this Brenner tumor, this condition is associated with a condition called as pseudomyx syndrome. Okay, so what is the pseudomyx syndrome? We'll discuss it later. Okay, but for now just remember, okay, for now just remember that the Brenner tumor is associated with a condition called as pseudomyx syndrome. Okay, pseudomyx syndrome. Okay, this is one point which I want you to know. Mixed syndrome is different, pseudomyx is different. Okay, done. Okay, so here you can see this is a mnemonic, just to use it as a mnemonic. Why I just kept a bus in the nest is because B for Brenner tumor. Okay, B for Brenner tumor, BU, bus, right? BU. U is going to be 100% unilateral, and S is going to be solid. Okay, S is going to be solid. So Brenner tumors are solid and always unilateral. And what about this nest? That nest should remind you Warthal cell nest. Okay, Warthal cell nest. Next, so far what we have completed? We have completed 3. Serous tumors are completed, mucinous tumors are completed, and Brenner tumors are completed. Now let's discuss about the endometrioid tumor and clear cell tumor. Simple endometrioid and clear cell tumors. Say both these conditions are associated with something called as endometriosis. Okay, so in the name itself is there, endometrioid tumors, endometrium like ovarian cancer, endometrium like ovarian cancer. Okay, so it's a malignant tumor, no doubt, associated with endometriosis. I have said you, endometriosis increases the risk of endometrioid ovarian cancer. Okay, so associated with endometriosis and endometrial cancer, those who have endometriosis and endometrial cancer, they can develop, in the future they can develop endometrioid ovarian tumors. Okay, so it's the most common ovarian tumor associated with endometrial cancer. If a person is having endometrial cancer, then they can get ovarian cancer of which type? Endometrioid type. So clear cell tumors. So clear cell tumors are malignant tumors, no doubt. Again, they are cancerous. Okay, both endometrioid tumor and clear cell tumors are cancerous, no doubt. Most common ovarian tumor, say the most common ovarian tumor associated with endometriosis. The most common ovarian tumor associated with endometrial cancer is endometrioid tumor. But most common ovarian tumor associated with endometriosis is clear cell tumor. Now, who can have this clear cell tumor, sir? Usually a females who have exposed to diethylstilbestrol. A female, if she is exposed to this drug which is called as a diethylstilbestrol, actually we don't use this drug nowadays, okay, which was used long back. So these females in the future can develop this clear cell type of ovarian cancer. So those females who were exposed to this drug called as diethylstilbestrol, they are at risk of developing which type of ovarian cancer? Clear cell. A clear cell. What else can be seen is hobnail cells are seen. Okay, hobnail cells are seen. Okay, so usually this cancer. Okay, so this cancer, clear cell cancer, it is going to produce certain paraneoplastic symptoms, or this clear cell tumors can cause hypercalcemia. How, sir? For example, imagine this is a cancer. This cancer is producing a hormone which is something related to the parathyroid hormone. Parathyroid hormone related peptide. Parathyroid hormone related peptide. These cancer cells are producing something called as parathyroid hormone related peptide. So unnecessarily the parathyroid hormone levels are increasing, or parathyroid hormone like hormone levels are increasing. So what it will do, it increases the blood calcium levels leading to hypercalcemia. So the question which was asked is, which of the following ovarian cancers are associated with paraneoplastic syndromes or hypercalcemia? Clear cell carcinoma. Which cancers are associated with endometriosis? 2 cancers. One is clear cell type as well as endometrioid. Endometrial, the person is having endometrial cancer, she can develop which type of ovarian cancer? Endometrioid variety of ovarian cancer, most commonly. If a female is having endometriosis, she is more likely to develop which type of ovarian cancer? Clear cell cancer. Diethylstilbestrol, clear cell cancer. So with this, the epithelial ovarian tumors are completed. Okay, with this the epithelial ovarian tumors are completed, sir. Now after the epithelial ovarian tumors, the next topic, okay, the next classification that we are going to discuss is the germ cell tumors. Okay, we are going to discuss about now which tumors? Germ cell tumors. So germ cell tumors, the first type is a teratoma. First let's discuss about teratoma, dysgerminoma, yolk sac tumor. Okay, these 3 are very important. Okay, next, embryonal cancer. So first let's discuss about the teratoma. Okay. So now let's begin our topic with the germ cell tumors. In the germ cell tumors, the first topic that I am going to discuss is called as the teratoma, sir. Okay. Yeah. Before discussing about the teratoma, first let me discuss about the tumor markers. First let me discuss about the tumor markers. Later on, I will discuss about the teratomas, dysgerminomas, yolk sac tumors, embryonal tumors. I will discuss. Okay. So germ cell tumors, they are going to be mainly seen in younger age groups. Okay, they are mainly seen in younger age groups. They present at very early age. What are the tumor markers? See, dysgerminoma, just now we are discussing. So we will discuss, for example, the first topic that we are going to discuss is called as a dermoid cyst, dysgerminoma, teratoma. Okay, see, different type of germ cell tumors produces different types of like hormones you say, are different types of markers. For example, dysgerminoma, look, dysgerminoma is producing what? Lactate dehydrogenase, human chorionic gonadotropin and PLAP. See, these are the tumor markers produced by dysgerminoma, which means in dysgerminoma, if a female is having dysgerminoma, these tumor markers are going to be elevated. If a person is having yolk sac tumor, if a female is having yolk sac tumor, then alpha fetoprotein, lactate dehydrogenase and alpha 1 antitrypsin levels are elevated. Okay. Now, if a female is having embryonal cancer, see what you will get it out, sir. What is this embryonal cancer? See, embryonal cancer is also nothing but germ cell tumor. Okay, choriocarcinoma is also a type of germ cell tumor. So, look here. In choriocarcinoma, what is the tumor marker HCG? In different types, okay, in different types of germ cell tumors, different types of markers are seen. But what are the exceptions? Some important exceptions I will tell you. Look here. See, teratoma. Teratoma, here have I mentioned any teratoma over here? No. So, teratoma, no tumor marker. Teratoma have no tumor marker, sir. Okay, teratoma, dermoid cyst I will discuss, but teratoma doesn't have any tumor marker. Lactate dehydrogenase. See, lactate dehydrogenase here. Okay, so lactate dehydrogenase is usually elevated in all germ cell tumors. Okay, all germ cell tumors except embryonal cancer and choriocarcinoma. Okay, it's not seen in choriocarcinoma or embryonal cancer. Their levels are not elevated. Next, alpha fetoprotein. See, alpha fetoprotein, here it is there, here it is there. So, alpha fetoprotein is seen in yolk sac tumors as well as embryonal cancer. All germ cell tumors except choriocarcinoma and dysgerminoma. So, in dysgerminoma, choriocarcinoma, it is not seen. Now, HCG. Sir, HCG, it's seen in all except yolk sac tumor. So, for example, look here, here it is HCG, HCG, HCG. It's seen in everything except the yolk sac tumor. Okay, so these are very important for your exam to identify the kind of tumor the patient is having. Okay, so you have to by heart it. And most of the time, these germ cell tumors, okay, are mostly unilateral. Okay, they are mostly unilateral, mostly seen in early age group. Okay, early age group. So having said that, now let's begin our topic with the dermoid cyst. So this dermoid cyst also called as teratoma. Okay, mature cystic teratoma. Okay, which is usually benign. Okay, usually benign. So it's the most common germ cell cancer. Okay, it's the most common germ cell cancer. So once it is cancer means it is immature. Immature cystic teratoma. Mature is benign. Immature is cancerous. Mature teratomas are benign. Immature teratomas are cancerous. Immature things, like the immature people are also more dangerous. Okay. So mostly unilateral, sir. Okay. It's the most common ovarian tumor in reproductive age group. It's the most common ovarian cyst during pregnancy. This ovarian cancer can undergo torsion. So three things. Which ovarian tumor will undergo torsion? Teratomas. What is the most common ovarian tumor during reproductive age group? Teratomas. Most common ovarian tumor during pregnancy? Teratomas. So teratomas. So if you look at a teratoma cell here, say the two things which are very much clear. See, there is a protuberance like this. Okay, there is a protuberance. So this protuberance is called as a Rokitansky protuberance. Okay, this is called as the Rokitansky protuberance. And what else you can say is, you can see the hairy material. Hairs are growing within the ovaries, sir. And sometimes you can see the tooth, okay, development of the tooth. So different tissues can be present now within the tumor. So the tissues of different origin, or I should say, so these teratomas, they are derived from multiple germ layers. Okay, they derived from multiple germ layers. Okay, the components of multiple germ layers can be seen. Hairs are seen, like sometimes cartilage can be seen, sometimes bone can be seen, sometimes the tooth can be seen. Okay, so these are the teratomas. Okay, most common tumors of reproductive age group, most common tumors in the pregnancy, most common tumors can undergo torsion. Mature teratomas are benign, immature teratomas are malignant, most of the time they are unilateral. Very 10% of the time they can be bilateral also, 10 to 15% of the time. So I have said you all components of the germ cell layers, okay, can be present. So it is made up of 3 germ layers. So sometimes you can see bone or teeth in this tumor, sebaceous secretions, hair can be seen, endometrial secretions, endometrial glands can be seen, sorry, endocrine glands can be seen. Okay, so these are the points which I want you to know. So mostly they are benign. Okay, teratomas are mostly benign. Okay, they are mature, mostly benign. But they can turn into cancers. Which area can turn into cancer? This Rokitansky protuberance, this protuberance is there, right? That's the most common site for the cancer. Okay, most common site for the malignancy is Rokitansky protuberance. And what is the chance of turning into cancer? 2%. Okay, 0.2 to 2% chance that they can turn into cancer. Okay, so malignant transformation too, if it is turning into cancer, now it's a teratoma is not a cancer. If it's turning into cancer, to which type it will turn? So it will cause squamous cell carcinoma. Okay, it will turn into squamous cell carcinoma of the squamous cell carcinomas. Okay, so okay, done. After this, what else I want you to know? This like the ultrasonographic findings. I just don't want to discuss here because you will discuss you will study them in your gynecology. Okay, so what is the management? Okay, she is having this tumor. Okay, teratoma, dermoid cyst is there. Teratoma, dermoid cyst is there. So what we have to do if her family is completed? Okay, if her family is completed, do oophorectomy, remove the ovaries. If her family is not completed, just do cystectomy, remove the cyst. Okay, done. Now, the next condition which I am going to discuss is called as a dysgerminoma. So far, what we have completed, we have completed this one thing. See, so far, we have completed the teratoma, okay, which is also called as a dermoid cyst, mature cystic teratoma. Second thing where we are going to discuss is dysgerminoma. Okay, so dysgerminoma. Let's see. So dysgerminomas are the second most common germ cell tumors. First most common is what? Dermoid cyst. Okay, first most common are the dermoid cysts. Second most common are the dysgerminomas. How they are, sir? Fleshy. They are going to be fleshy, lobulated, creamy colored tumors. Okay, so creamy. Okay, they are fleshy with the lobules. Multiple lobules are going to be seen. Okay, multiple lobules. This thick septa are there. Okay, multiple lobes are there. See, these are the multiple lobes are present. Okay, so what else we have to know is, sir, this dysgerminoma, if it occurs in testis, the same pattern, whatever is there, in testis it is called as a seminoma. Okay, so the ovarian counterpart is a testicular seminoma. In the males it is testicular seminoma, in females it is dysgerminoma. So it is unilateral, okay, but in bilateral it can be 10 to 15% of the females, but mainly see always unilateral. These germ cell tumors are there, right? Germ cell tumors are mostly unilateral. Okay, that's the point which I want you to know. It's the most common ovarian cancer in dysgenetic gonads. Okay, dysgenetic gonads, the gonads which are not properly formed. For example, maybe in cryptorchidism. Okay, imagine there is a female, not a female, actually it's a male, but looking like a female. Okay, male looking like a female. For example, like androgen insensitivity syndrome. The patient is having androgen insensitivity syndrome, where a male is looking like a female. These gonads are there, right? These gonads, they are still present within the abdomen. So these gonads are not properly formed, dysgenetic gonads. So these gonads, dysgenetic gonads can turn into cancers. Which cancers? Dysgerminoma, or in male seminoma, dysgerminoma or seminomas. So it's the most common ovarian cancer in dysgenetic gonads. It's the most common ovarian cancer during pregnancy. Okay, during pregnancy, see, it's the most common ovarian cancer during pregnancy. Now look here. Here in dermoid cyst or teratoma, I have used the word most common ovarian tumor system, not the cancer. The most common ovarian cancer during pregnancy is the dysgerminoma. The most common ovarian cyst or ovarian tumor during pregnancy is the teratoma, which will undergo torsion. Okay, don't forget about that. Next, so it's the only radiosensitive ovarian tumor, means very much treatable with radiotherapy. Okay, highly radiosensitive is dysgerminoma. Okay, so what else you should know for your exam? See, nests of cells separated by fibrous septa. Okay, here what you can say. So these are the nests of cells, sir. Okay, Walthard cell nest. Okay, so Walthard cell nest we have discussed. Where we have discussed about the Walthard cell nest? The bus in the nest. Okay, the bus is there in the nest. What is the type? Don't forget. So the bus in the nest is nothing but the Brenner's tumors. Okay, that's a Walthard cell nest. Now here I am talking again, nests of cells are seen, but they are separated by thick septa. Then in dysgerminoma, it's the only tumor which is highly radiosensitive. Nests of cells are separated by thick septa. Okay, so what else? So the cells are going to show the fried egg appearance. Okay, the fried egg appearance, the central nucleus with the perinuclear halo. The central nucleus, okay, the central nucleus, say, is the central nucleus with the perinuclear halo. It is going to show the fried egg appearance. Okay, just take an egg, just crack it and put it on the pan. So how it's going to be like an omelette, like with the central yolk is going to be yellow in color in the center, surrounding by the white, the egg white. So fried egg, it's a fried egg, sir, omelette. Okay, so fried egg appearance is going to be seen. Okay, so fried egg appearance is seen. The cells are going to look like a fried egg, and the tumor nests. Okay, the tumor nests are separated by the thick septa, and in the septa, what you can see is the lymphocytes. Okay, the septa are infiltrated by the lymphocytes. Okay, so it's going to show the best prognosis. These germnomas are having the best prognosis among the other germ cell tumors, and the tumor marker I have already explained you. These germnomas tumor markers are LDH, PLAP, and HCG. These germnomas tumor markers. Okay, don't forget LDH, PLAP, as well as HCG. Okay, these germnomas LDH, PLAP, and HCG. Okay, so for me, again repeat, what are the important points that you should know regarding the dysgermomas? Is this second most common germ cell tumors? Second most common germ cell tumors, mainly unilateral, most common cancer during the pregnancy, highly radiosensitive with good prognosis, nest of tumor cells separated by the thick septa. The thick septa are infiltrated by the lymphocytes. In male, it is called as seminoma. What are the tumor markers? PLAP, beta HCG, as well as LDH. So done. So the next tumor that I am going to discuss here is yolk sac tumor. Sir, this yolk sac tumor, what are the important points you have to know? The most malignant out of all, this is the worst fellow. The most malignant germ cell tumor. Okay, the most common germ cell tumor, the most malignant, I should say, the most malignant germ cell tumor is this yolk sac tumor. How it's going to look like, sir? It's going to have a lot of hemorrhage. Okay, so a lot of hemorrhage, sir. See, a lot of hemorrhage is seen. This tumor, reddish color. A lot of hemorrhages are seen. The most rapidly progressive tumor, that's why most malignant. Okay, rapidly progressive, it will cause the metastasis. The germ cell tumor with the worst prognosis. Who is having the best prognosis? Dysgermomas are having the best prognosis, but yolk sac tumors are going to have the worst prognosis. 100% unilateral. HPV findings are going to be Schiller dual bodies are going to be seen, or glomeruloid body. The Schiller dual bodies or glomeruloid bodies are going to be seen. See the tumor cells, this is a blood vessel. In the center there is a blood vessel. This is a row of tumor cells. Okay, this is one row of tumor cells. Okay, and there is one more row of tumor cells in the periphery. Okay, this is one more row of the tumor cells in the periphery. In the center, what you can see is this clearing, central clearing, white color is there. Okay, so this is called as a Schiller dual body. Tumor cells surrounded by a blood vessel or a capillary. In the center there is a capillary. See, central capillary surrounded by the tumor cells. Okay, with a cystic space. So this is called as a Schiller dual body or glomeruloid body. So Schiller dual body or glomeruloid body are seen in yolk sac tumors. Done. What are the tumor markers? Already explained to you. AFP, alpha fetoprotein, LDH, and alpha 1 antitrypsin. The beginning also I have explained. Okay. So tumor markers are alpha fetoprotein, LDH, and alpha 1 antitrypsin. Never produces the beta HCG. Beta HCG is not seen. This is a question. Beta HCG is not produced by the yolk sac tumors. So with this, what we have completed? We have completed the teratoma, dysgerminoma, yolk sac tumors. Okay. So these are the three important things which I want you to know. Okay, here I have discussed everything: serous tumors, mucinous, Brenner's, endometrioid, clear cell tumors. I have discussed everything. Here, these are the three types which I want you to know for your exam, especially from the pathology. Okay, I am just giving more information. Okay, like more than pathology I am giving. I am just trying to integrate as much as with the gynecology. Now let's discuss about the sex cord stromal tumors. In the sex cord stromal tumors, the one tumor which I want you to know is granulosa cell tumor. Sir, what are these granulosa cell tumors are doing? Sir, they produce estrogens. These granulosa cells, normally the granulosa cells which are surrounded by the follicles, they produces the estrogen. If you are having a tumor of these granulosa cells, then they will produce lots and lots of estrogen. Okay, so this estrogen is going to cause the symptoms. So granulosa cell tumor, what are the important points which you should know? It's the most common type of sex cord stromal tumor. Okay, most common sex cord stromal tumor is granulosa cell tumor. Okay, it's arising from which cells? Granulosa cells. Why? Because of this mutation. Okay, FOXL2 gene mutation. It secretes what? Estrogen. Sometimes progesterone. Okay, estrogen and progesterone. What are the adult subtypes? Sir, adult subtype is going to present with menstrual irregularities because of lot of estrogens, all these problems. Menstrual irregularities are going to be seen. So what are the menstrual irregularities that are seen with this granulosa cell tumors? The granulosa cell tumors are going to cause a menorrhagia, excessive bleeding, because exoestrogen is there. Exoendometrial proliferation, more endometrium means more bleeding. So menorrhagia can be seen, or abnormal uterine bleeding can be seen. Because of the estrogens, there can be breast tenderness, post-menopausal bleeding, endometrial hyperplasia, more and more hyperplasia of the endometrium. It can lead to endometrial cancer, true. Okay, the endometrial cancer is because of high levels of estrogen. Why the high levels of estrogen? Granulosa cells are producing the high estrogens, hyperestrogenic states. Okay, they are producing more and more estrogens, so leading to the hyperestrogenic states. Okay, so if you do the endometrial sampling, okay, so endometrial sampling should be done for all females with a granulosa cell tumor. For example, imagine this is a female with a granulosa cell tumor. Okay, now she is having ovarian tumor, but what you have to do, you have to take the endometrium and you have to check it, because there is a chance that she can get endometrial cancer because of hyperestrogen levels. So hyperestrogen levels can lead to endometrial hyperplasia initially, and that endometrial hyperplasia can lead to endometrial cancer. Okay, so adult subtype is going to cause this menstrual abnormalities, but if it occurs in the juvenile, okay, if it occurs in the younger age groups, for example in a 8-year-old or 9-year-old, because of this excessive estrogen levels, she is going to have precocious puberty. Okay, she is now this female who is, for example, 8 years old, she is having the breast development. Okay, so she is having the precocious puberty is seen. Okay, now what you will see on the histology set, on histology there is going to be Carl Exner bodies. Okay, so Carl Exner bodies are seen. Okay, so what exactly is this Carl Exner bodies? This is nothing but the granulosa cells arranged in clusters surrounding a central cavity. In the center, there is a cavity surrounded by all these granulosa cells. All these are the granulosa cells surrounding a central cavity. Okay, so in the central cavity, what you will see, the pink color material, the eosinophilic material is going to be seen. Okay, with the eosinophilic secretions. So this is called as the Carl Exner bodies. Carl Exner bodies seen in granulosa cell tumors. Sorry, granulosa cell tumors, Carl Exner bodies. Adult subtype, menstrual irregularities. Juvenile subtype is going to present with precocious puberty. Okay, this granulosa cell tumor increases the risk of endometrial cancer. So if a female is having granulosa cell tumor, then you have to check for the endometrium. Okay, you have to check for the endometrial hyperplasia. Like if there is any atypical endometrial hyperplasia is there, we have to check for it. Okay, what are the tumor markers? The tumor markers are going to be inhibin and AMH, anti-Mullerian hormone. Okay, the tumor markers are inhibin because these are the granulosa cells. The granulosa cells produce inhibin, true, and anti-Mullerian hormone. Okay, or Muller inhibiting factor. Simple. Okay. Now, serotolinic cell tumors. Now, look here on the male counterpart. Okay, or I should say actually the androgen secreting, not the estrogen secreting, androgen secreting. So, if a female is having this serotolinic cell tumor, she is going to have high levels of androgens. So, let's put it this way. Serotolinic cell tumors, usually they are benign. Okay, what they secretes? Androgens. They are secreting the androgens. Which age group is going to be affected? 30 to 40 years of age group is going to be affected. On histopathology, what you will see? On histopathology, it shows seminiferous-like tubules. Okay, seminiferous-like tubules lined by Sertoli and Renick's crystals. Okay, you can see this crystals, crystalloid appearance. Okay. Okay, this crystals, this is important. When you see such crystals on biopsy from the ovary, these are called as Renick's crystals. It's going to be seen in serotolinic cell tumors, high levels of androgens. Okay, seminiferous tubule-like appearance is going to be seen in the histology. So, what these androgens are going to do? You know it, the androgens are going to cause the hirsutism, male-like features. Okay, in males it will cause baldness. Okay, in females what it will do? Male pattern hair loss will be seen. Okay, she is going to have a hirsutism, development of the male characteristics like low pitch voice. Low pitch voice is going to be seen. Like development of the the facial hair, hirsutism. Okay. Androgens can cause the clitoral enlargement, breast will undergo atrophy. Okay, all these things are going to be seen. Okay. Now the point which I want you to know is, see, if a female is having ovarian or adrenal tumors, see with this adrenal ovarian tumor, which ovarian tumor? This serotolinic cell tumor. She is going to have high levels of androgens, super high levels of androgens. Okay. She is having adrenal tumor of the adrenal cortex. Again, she is going to have high levels of androgens. That high levels of androgens is going to cause rapid onset hirsutism. She is going to get the male-like features, but very fastly. Okay, with very fast pace, she is going to have the virilization. But if she is having, see, if they ask you, what is the most common cause of hirsutism? That is PCOS. So it's going to be gradual onset, not fast onset. Okay, it is adult onset, insidious onset means slowly, slow poison kind of thing. Slowly, slowly the hirsutism features will develop. Okay, but ovarian tumors are adrenal tumors is going to cause rapid onset hirsutism. Okay, so done. The next thing which I want to discuss here is a fibroma. Okay, so fibroma is also a stromal tumor. Okay, fibroma is a stromal tumor. Now, the point which I want you to know in the fibroma is, look, sir, these fibromas are benign unilateral tumors. What you will see in the histology is lots and lots of fibroma. In the name itself, it's a lots and lots of fiber deposition. Like the fibroblasts are going to be seen. So clusters of spindle cells, which are nothing but, okay, here I haven't shown the histology, but anyway, the clusters of spindle-like fibroblasts are going to be seen on the histology. So it's associated with fibromas are associated with a syndrome called as a mixed syndrome. Okay, so there is a syndrome called as a mixed syndrome in which the patient is going to have a fibroma in the ovary. Okay, look here, this female, she is having a mixed syndrome. She is having a fibroma in the ovary, and also she is having, see, the lung involvement. What is that lung involvement, sir? The pleural effusion is going to be there, and she's also going to have the ascites. See, if the fluid accumulation in the peritoneal cavity, actually her abdomen should be something like this. Okay, so peritoneal fluid accumulation, ascites, there can be pleural effusion and fibromas in the ovary. So this kind of condition is called as a mixed syndrome. Okay, mixed syndrome. Pseudomixed syndrome we have discussed. Okay, in the mucinous, okay, in the mucinous, the tumors of the ovaries, we have seen the pseudomixed syndrome. Okay, done. This is also completed. And the last thing which I want you to know here is a Krukenberg tumor. What exactly is this Krukenberg tumor? Okay, what exactly is this Krukenberg tumor? See, Krukenberg tumors, these are the metastatic tumors to the ovaries, which means the cancer have originated in the stomach. See, now this is the gastric cancer. Now the gastric cancer is coming to is spreading to the ovaries, and the cancer is growing in the ovaries. So these tumors are called as the Krukenberg tumors. See, metastatic spread most commonly from the gastric cancer or from the breast cancer. So how the cancer is spreading? Cancer spread to the ovaries via the retrograde lymphatics, via the retrograde lymphatics. Okay, via the retrograde route, the cancer is spreading to the ovaries. So this ovarian cancer is called as the Krukenberg tumors. Okay, tumors are often bilateral. Okay, most of the time the cancers are going to be seen both the ovaries. There is a capsule, sir. Okay, these ovaries are going to have, sorry, these tumors are going to have the, not tumors, these cancers. These cancers are going to have the capsule. Okay, that's the point which I want you to know. Okay, so these are the important points which I want you to know regarding the ovarian cancer. In the topic of ovarian cancer, see, I have discussed most important ovarian cancers. The most important ovarian cancers are discussed. Okay, especially the epithelial ovarian tumors. Okay, the epithelial ovarian tumors are very, very important for your exam. So with this ovarian cancers, which you need to know from pathology, if you know this much, that's more enough, sir. More than enough. Okay, also we have discussed about the infections. Also we have discussed about the ovarian tumors. So with this, I'm ending this session. Okay, see you in the next video. Thank you.